Hello, I'm Dr. Mihir Patel, third year radiology resident from New Civil Hospital, Surat. I would like to thank Dr. Purvi Desai, Professor and HOD, for guiding me while making this paper. My paper topic is the Great Mimickers, a case series approach to ring enhancing brain lesions. Background introduction. Ring enhancing lesion of the brain represent a heterogeneous group of pathologies sharing a common imaging appearance, peripheral contrast enhancement surrounding a non-enhancing core on CT or MRI. Despite the uniform radiological pattern, the underlying etiologies span neoplastic, infectious, vascular, and demyelinating disease, each demanding vastly different management strategies. Accurate radiological characterization is therefore critical to guide timely clinical decision making, avoid unnecessary biopsy, and initiate appropriate therapy. Differential diagnosis can be remembered by mnemonic magic doctor, metastasis, M, A abscess, G glioblastoma, I infarct, C contusion, D demyelination, and R radiation necrosis. Neoplastic etiologies include glioblastoma, metastasis, primary CNS lymphoma, high-grade astrocytoma, infectious disease which is most commonly seen in Indian population, pyogenic abscess, tuberculoma, toxoplasmosis, cysticercosis. Vascular include subacute infarcts, hematomas, radiation necrosis, tumefactive MS. Aims and objectives is to study the MRI spectrum of ring enhancing lesions of the brain and correlate the imaging findings with clinical and pathological diagnosis. We'll characterize the MRI features, evaluate the advanced MRI sequences, establish the imaging criteria, and clinical radiological correlation will be done. Materials and methodology. This retrospective case series includes 30 patients presenting with ring enhancing lesions on Siemens 1.5 Tesla MRI machine. Lesions were analyzed based on morphology, DWI, ADC, contrast enhancement patterns, and associated findings. MRI protocol included T1, T2 flare, DWI with ADC, and T1 with contrast, and MR perfusion. Inclusion criteria. Patients with one or more ring enhancing lesions on contrast enhanced MRI brain were included, excluding incomplete imaging data and poor image quality. Glioblastoma multiforme. 58-year-old male patient with progressive headaches in 6 weeks, right hemiparesis and aphasia, new onset seizures, papilloedema on fundoscopy was seen. Imaging summary. Heterogeneous irregular mass lesion is seen at the bilateral frontal region with predominantly T1 hypointensity and T2 hyperintensity. Superimposed T1 hyperintensity represents foci of hemorrhage. Evidence of hemosiderin deposition is also seen within the tumor mass. Irregular thick walled peripheral rim enhancement is seen. Evidence of restricted diffusion at the solid component of the peripheral aspect, whereas the central necrotic region shows no restricted diffusion. Appearance of restricted diffusion heterogeneous. Post contrast sequence is showing the predilection of the tumor in the white matter and the tumor is spreading across the corpus callosum. Second is cerebral metastasis. A 62-year male presented with sudden headache and right facial drooping, confusion, vomiting, and a patient was a known case of lung adenocarcinoma. Image summary shows cystic tumor masses are seen at the left frontal and parietal lobes, with the predominantly large cystic lesion at the left parietal lobe causing significant mass effect. The perilesional T2 hyperintensity was due to the vasogenic edema. Irregular peripheral ring enhancement with focally thickened wall was suggestive of malignant lesion. Third, pyogenic brain abscess. A 34-year-old male patient presented with fever, focal left side weakness, and the patient had a recent dental extraction. The WBC CRP counts were raised. Imaging summary. The lesion was T1 hypointense and T2 hyperintense. The abscess wall appeared T2 hypointense. Mild subarachnoid hemorrhage is also seen at the right frontal sulcus. Post contrast imaging showed thin, smooth wall peripheral ring enhancement at the abscess. Pyogenic abscess course shows restricted diffusion on DWI. And marked perilesional edema was also noted. Fourth case was cerebral tuberculoma. 28-year female patient presented with chronic headaches since 3 months. Patient had low-grade fever, night sweats, weight loss. Montauk test was positive and had a positive contact history for TB. CSF showed increased lymphocytes, increased protein, and decreased glucose. T1 contrast showed diffuse leptomeningeal enhancement around the basal cistern, which was suggestive of tubercular meningitis. On follow-up scans, there were some lesions at the supracellular and the left quadrigeminal cistern, suggestive of tuberculoma. The lesion at the right supracellular cistern is T2 iso-intense, and the lesion at the left quadrigeminal cistern is T2 hyperintense, which was suggestive of internal caseating content. Ring enhancement is noted at the tuberculoma on post-contrast MRI imaging. Fifth case was cerebral toxoplasmosis. A 41-year female with HIV, known case of HIV, was non-compliant on ART since 6 months and had a CD4 count of 68 cells. Patient had left hemiparesis, seizure, and fever. Axial T1 weighted image shows a hypointense area in the right basal ganglia associated with mass effect. Flare showed a hyperintense lesion in the right basal ganglia, and T1 contrast showed a ring enhancing lesion in the right basal ganglia. Multiple sclerosis, tumefactive multiple sclerosis. 26-year female presented with right arm weakness, which was progressive since 3 weeks, which was a prior episode of visual blurring, and CSF had oligoklonal bends positive. T1 MRI with contrast axial image showed left frontal ring enhancement lesion with enhanced venules. T1 coronal contrast showed incomplete ring enhancement of the same lesion with open ring towards the cortex. And flare showed hyperintense lesion in left frontal lobe with surrounding vasogenic edema. Seventh case was of subacute intracerebral hematoma. A 52-year male presented with altered sensorium, vomiting, left-sided hemiplegia. Known case of hypertension, poorly controlled. BP was 190 by 110. NCCT brain showed hypodense lesion with peripheral hyperdensity at the right frontal lobe. On MRI, the lesion is T1 and T2 hyperintense. A complete hemosiderin rim is seen on T2 weighted image. A mild degree of thin ring enhancement is seen on post-contrast image. It can persist for a few months even after the lesion becomes T1 and T2 hypointense. DWI and ADC are showing restricted diffusion. Eighth case, neurocystic sarcosis. A 24-year male patient presented with generalized tonic-clonic seizure and had 3 episodes. There was mild headache, no fever, no focal neurological deficit, and patient had a family history with sibling with similar seizures. A well-defined ring-like lesions were seen in cortical subcortical location of right parietal lobe involving the postcentral gyrus and posterior parietal lobule. These reveal hypointense rim with central hyperintensity on T2 weighted images, which is iso to hypointense on T1 weighted images. There's eccentric dot-like hypointensity which appear to represent scolex. There was no restriction diffusion. There's mild to moderate perilesional edema noted. There were a total of 30 cases with 4:3 sex ratio, and the age range was 20 to 62. Most of the cases I had were of tuberculoma and neurocystic sarcosis with 23% each. And the bar diagram demonstrates frequency of different causes of ring enhancing brain lesion, highlighting the predominance of infectious etiologies in India. Key imaging observation: DWI was the single most discriminating sequence. Restricted diffusion core was 100% specific for pyogenic abscess in our series. T2 rim signals differentiated TB from abscess. A T2 hypointense rim due to fibrosis, calcification, paramagnetic free radicals were exclusively seen in tuberculoma. All other rings lesion had T2 bright or variable rims. Non-contrast T1 hyperintensity subacute hematoma. T1 bright core without contrast injection is pathognomonic of subacute blood due to methemoglobin. SWI blooming artifact confirmed hemorrhagic products. The open ring sign was pathognomonic for demyelination. The incomplete ring enhancement opening towards the cortex was seen in tumefactive MS and was not observed in any neoplastic or infectious case in this series. The eccentric T2 dark scolex nodule within a T2 bright cyst was seen exclusively in the NCC case. Multiple lesions at different evolutionary stages simultaneously or highly characteristic and not seen in any other diagnosis. Discussion: a systematic 5-step MRI approach to ring enhancing lesions. Ring morphology: thin versus smooth versus thick versus irregular versus open. So thin smooth is seen in abscess and Mets. Thick irregular seen in glioblastoma multiforme. Open/incomplete is seen in multiple sclerosis. DWI: does the core restrict? Core restricted is seen in case of abscess. No restriction can be seen in neoplasm, TB, MS. T2 dark rim is seen in case of tuberculomas due to calcification and fibrosis. T2 bright is seen in case of abscess, neoplasm, and MS. Number and location also helps. Multiple at gray white matter junction is likely suggestive of metastasis. Multiple in case of in basal ganglia in HIV positive patient is basically suggesting toxoplasmosis. And if it is periventricular in location, it suggests MS. An advanced MRI in case of regional cerebral blood volume and MR spectroscopy. Increased regional RCBV is seen in case of GBM and METs. Decreased in case of abscess, TB, MS, and radiation necrosis. Increased choline is seen in case of tumors. In amino acids is seen in abscess. For example, in tuberculoma, there is a lipid peak. Conclusion: DWI is non-negotiable. Core restriction is also pathognomonic for pyogenic abscess and must be acquired in every ring lesion evaluation. T2 dark rim indicates tuberculoma. T2 bright core indicates abscess. A simple but critical distinction. Incomplete cortex sparing enhancement in a young patient is suggestive of tumefactive MS. Therefore, steroids should be done before taking biopsy. HIV status, fever, age, and history of prior malignancy or radiation should frame every radiological interpretation. Thank you.